Our team case analysis focuses on case three, the new department director. Dr. Grant was recently hired as the new ambulatory care director at Kennedy Medical Center. He immediately noticed there were serious problems in the emergency department. Some of these organizational problems include lack of shared concern by stakeholders, long wait times, capacity issues, frequently diverting ambulances to other facilities. His ultimate goals were to process 90% of emergency department outpatients within 4 hours and to redirect patients to other hospitals no more than once a month.
There were multiple stakeholders involved here. There were the patients, there were the prospective patients, and the people in the community who were served by this medical center or anticipated to be served by the medical center. There was the clinical staff, there was hospital administration, other hospitals in the area. You have to think about, we don't know what type of area this hospital was in, so it could have been in a rural area where it was a regional referral center for other smaller facilities. Any financial donors or foundations that contribute financially, and then the board of directors.
So we talked a little bit about the general organizational problems, but we wanted to break it up by levels. So starting at the smallest with the individual level, there was a lot of employee frustration within this case. And it seemed like some of that stemmed from a lack of understanding of the department structure itself and a lack of understanding of the initiative that Dr. Grant was trying to bring up upon the department. Beyond that, if you zoom out a little bit on the team level, there seemed to be a lack of shared vision within the team and within the organization itself. And then for this initiative, there was not clear leadership of who was in charge of implementing this initiative. And with that, there was not clear communication or organization. And then on the highest level, looking at systems level, were the problems that Dr. Grant was hoping to address. So, there was inefficient flow of patients through the department, but the initiative was not able to be implemented because of inadequate staffing. And beyond that, there was also insufficient physical space for the patient burden that this emergency department was trying to serve.
So, to think about this issue, we examined path goal theory, and that was developed in 1971 by Robert House. It emphasizes a top down approach to leadership in which the leader can have either a positive or a negative impact on the whole group's motivation to progress towards a shared goal. So, the leader should examine the situation and remove any obstacles to reach the goal, and they should examine intrinsic and extrinsic sources of motivation for the group in order to increase rewards for good performance. Leaders should adapt their style contingent on the situation that they're facing, and parts of this theory are based on the expectancy motivation theory, and that outlines employees' expectations of a reward for their performance. But in addition to that, it adds on the idea that situational factors also influence motivation. So there are multiple things that influence outcomes, including leader behavior, and that's classified in 4 different categories. So the first is directive, where clear expectations and guidelines are provided. Supportive is where the leader is a little bit more approachable and they demonstrate concern for the employee's well-being. Achievement-oriented is when leaders set specific goals and they expect confidence and power in their team to achieve those goals. And participative leaders consult subordinates and apply their suggestions in order to meet the goal. So situational variables are also considered through this theory, and they include subordinate and task characteristics. So subordinate characteristics are qualities that the team members each possess and bring to the table. So the leader must consider the employee ability, their motivation, self-esteem, their need for an affiliation, their preference for like a more rigid, structured environment versus more autonomy and ability to make their own decisions. And then task characteristics include rigidity, emotional weight, how intellectual something is, if it's complex, if it's safe. And so leaders should consider the characteristics that the task that they're asking of their team, and then they should attempt to compensate for something that may be less filled by the task. So a good example of this is to think about a task that's highly rigid and complex, and a leadership style that would be better suited to combat that would be someone who's more flexible and gives a little bit more one-on-one support to the employees. So we have some satirical videos to kind of demonstrate in short clips each leadership style. So the first is directive.
Now, Jim is going to be the client. Dwight, you're going to have to sell to him without being aggressive, hostile, or difficult. Let's go. Now, Jim is
So,
going to be the.
oh, sorry, that was directive. Next is supportive.
I told Dwight that there is honor in losing, which, as we all know, is completely ridiculous. But there is, however, honor in making a loser feel better, which is what I just did for Dwight. Would I rather be feared or loved? Easy, both. I want people to be afraid of how much they love me.
And then the next two are achievement oriented.
Everybody, in the last year, we have lost 7 clients to the big chains. These gift baskets are a ticket back into their lives. We're going to show up at these businesses unannounced, and we are going to win them back. We need to get
And
things
finally,
going. We need to get
participative.
percolating a little bit. Anybody have any ideas what we could do? Any suggestions? Yes, Andy.
What if we changed our outgoing answering machine message so it just had a little more zing and a little more pep?
Zing and pep. See, those are the kind of words we're looking for. Yes, Jim.
So those are kind of some fun examples of the styles.
Next, we will review Dr. Grant's leadership style. Dr. Grant did not take the time to understand his subordinates' characteristics. His leadership also lacked sufficient supportive factors such as coaching. He was directive. His directives were to understand the root cause analysis, redirect flow of department to see the physician faster, and to alter the electronic registration system. However, he did not give enough structured direction. So he had big ideas, but not necessarily enough follow through. Additionally, Dr. Grant's leadership was not participative. He did not welcome others' ideas. He was achievement oriented. His goals were to see 90% of patients within 4 hours and to divert patients to other hospitals only once per month. But however, this did not fit the situational variables. The subordinates did not respond well to this. One such example is when he was trying to get staff on board with this initiative, the manager actually walked out early. And there was just overall not great response. The task variables also did not fit with this, as the solution exposed a lack of staff to carry out the plan. So very quickly, they realized that they weren't going to have enough capacity to carry this through.
So then next, we wanted to look at a logic model of all of the factors that played into this initiative and what we hope to accomplish. So this is basically just imagery looking at the relationship between all of the key inputs, outputs, and outcomes. So in our situation here, we were looking at, slow workflow in the ER and patients often being diverted to other hospitals. And priorities on our initiative are, utilizing the organization's mission and shared values, as well as the patient experience in deciding what we're going to do. And so our inputs for this project are, the planning time and the training time to get staff on board and the knowledge base they will actually gain from that training. As well as money. Money would be required, especially for the new materials to complete this initiative. Then moving on to the outputs, I broke this down into who we reach, what we plan to do, and what we hope to create. And so who we reach are both our returning patients and possible new patients if they didn't have to be diverted to other hospital systems. And then what we plan to do is train our physicians on leadership. So we need to conduct workshops and training implementation for this initiative. This also involves needing to designate workload because that was a large problem in Dr. Grant's initiative where nobody really knew what was their responsibility and it all kind of fell apart. And then we need to facilitate that implementation through leadership. And then beyond that, we hope to create a more efficient work environment and more accessibility to the emergency care that we're trying to provide to the community that this hospital serves. This also includes decreasing patient transfers to other hospital systems and a better overall care model for our patients. So then outcomes are broken into short-term, intermediate, and long-term for this project. So short-term, we hope to increase the knowledge base of our staff and build new skills for the staff so that we can reach the goals of this project. Then intermediate, we hope to have more actionable items, an actionable approach in the ER, and to build more cohesion as a team among staff members. And then long-term, of course, our objectives are the same as Dr. Grant's, where we hope to have shorter wait times and better access to emergency care overall. And it's important to remember, too, that there are other external factors that play a role in each of these things as well, including stakeholders and community expectations of the hospital, as well as what other emergency departments are doing within the region.
So in order to come up with this, we looked at previous evidence. So if you've never worked in an emergency department before in a clinical environment, the top photo is a picture of an emergency department board, which is what we use to track the patients in the department. And the red box is around an area that's titled LOS, which is length of stay. So the paper that we examined attempted to change the flow of the emergency department by implementing board rounds every 2 hours, which is where the physician reviews the patient board every 2 hours and specifically focuses on length of stay and then reviews why a length of stay may have been outside of the goal metric. Past studies have actually shown that physician leadership courses can decrease boarding time by 68%. And the specific study that I reviewed, the boarding time went from 80 some minutes to only 20 some minutes, which is a huge difference in the amount of time that a patient spends in the department. The provider has to converse with the team members regarding wait times, and kind of figure out what bottlenecks are existing, what barriers are there to getting the patient moving faster to determine if they can go home or if they're going to be admitted. And then through this study, they used the PathGoal tool, and this showed what leadership styles the physicians were using when they were having these types of conversations. And they found that most physicians were using a directive leadership style, which wasn't necessarily ideal for this high stress and fairly rigid environment. And they found that the physicians who used a supportive leadership style were a lot more effective. And then they also found that physicians who were trying to use achievement-oriented or participative leadership styles were not implementing them correctly, and therefore they were not effective. So they really needed more training on how to do this appropriately.
So with our plan to really work on leadership styles with physicians, we had to decide, is this feasible or is it innovative? And we decided this is a fairly feasible plan. As Jane was discussing, this has been implemented in other emergency departments throughout the United States before, and the board rounds has been shown to have better outcomes in the long run. So there are some limitations to our approach, though, where, it is complex and requires a combination of leadership styles for different situations. And when you're looking at top-down approaches like this, it really requires modeling by the leaders, specifically the physicians in this case, and not everyone is able to take on all leadership styles. So that could really be a barrier to our approach and our hopeful plan. So alternatives we looked at include the organizational change theory, which really encourages organizations to be more innovative and have a more growth set mindset, and to explore new opportunities over and over again. So that would then require a more innovative initiative. And so some of them that we explored are explained in this paper by Jarvis, and include completely scrapping the traditional triage process altogether and requiring earlier rooming of patients so that you can cut down on wait times. Or another innovative initiative is the actual location of a primary care physician within the ER, so that lower acuity patients could be seen down this path by a primary care physician rather than also having to be seen by an emergency department physician who would probably be trying to balance some of the higher acuity patients as well.
In order to implement some of these changes, it is very important to make sure that we improve team effectiveness within Kennedy Medical Center. One way to do so is through the evidence-based team intervention SMART. This could be a valuable approach to improve communication and workflow at the center. Specific, measurable, attainable, relevant, and time-bound are the aspects of SMART intervention. Specific, Dr. Grant will improve communication and streamline workflow in the emergency department. Measurable, it would include an initial survey that will provide baseline information on challenges and barriers faced within the emergency department. It will also have a multiple choice and candid feedback section, so staff can kind of provide suggestions on how to improve patient care and clinical workflow. Attainable, Kennedy Medical Center has compassionate, patient-centered staff committed to improving patient health outcomes. As healthcare employees, we recognize that effective communication is critical to increase efficiency and improve patient care. And this is also incredibly relevant because there have been an increase in a number of patients diverted to other hospitals, limited staffing, limited resources, and overcrowding, which poses a major danger to patients and also results in poorer health outcomes. This is time-bound, and Dr. Grant will check in each month to review survey responses, and he will use the feedback from staff to implement necessary changes. And that will also, improve collaboration in the workplace. Motivation, even with implementation of the evidence-based team intervention SMART, the success of the program is still dependent on buy-in from staff. So there are several ways to do so. Based on a 2020 article by Open Health Group, there are several ways to engage and motivate staff through training. Analyze need, establish clear outcomes, and provide relevant resources. Listen to staff feedback. Show your staff that you value their well-being. Help them prioritize training during work hours, and keep lines of communication open, which is key. Also work with HR to establish links between training, progression, and promotion. Based on our evaluation on Dr. Grant's approach, we recommend PathGoal theory as a way to implement positive change and improve workflow at Kennedy Medical Center's emergency department. We also propose the evidence-based team intervention SMART as a way to increase communication and motivate employees. We are hopeful these initiatives will improve wait times and provide better access to emergency services at Kennedy Medical Center.